have Dr. Samir Parikh, a psychiatrist as well as director of the Fortis National Mental Health Program.
Thank you. Thank you. Now, I was thinking about this topic that you had, and I'll tell you my first honest reaction to it was, why is the need to discuss it? You know, and the thought came to my mind primarily because what are the odds of this being a cardiac conference? And one is talking about the efficacy of, let's say, stents. Yes, one can discuss the efficacy and the evidence of a newer stent or something like that. So when most healthcare conversations happen or most health related conversations happen, the fact that we need to ask what is evidence based and what is effective or not ideally should be a given. Then when we talk about something, whether it's from therapy's point of view, whether it's a CBT or DBT, or whether it is medications, or whether it is electroconvulsive therapy, or whether it is any other form of treatment that has been there in the field of mental health. But a lot of times these questions keep coming and keep coming. And I think we should first ask ourselves why the question comes. Second, ask ourselves what can we do about it. And third, the obvious, is there evidence to it? So let's understand this. Go before 50s, 1950s. You did not have any medications which were there for psychiatric problems. You had psychiatric disorders. You knew there is a problem. You could even identify, but you didn't know what to do with it. When initially medications came in, they obviously had a lot many more side effects as compared to also the obvious effect, chlorpromazine being amongst the first ones, when you were able to see an improvement in psychosis, but they would also give a lot of sedation, that vegetative-like feeling that you would feel that if a person takes it, there will be a lot of sedation, you will not be able to lead normal life. From there, things moved forward. In between, electroconvulsive therapy came, and a lot of aspects of electroconvulsive therapy today that people still think that it's an inhuman form of treatment, don't realize that it happens under general anesthesia, and it happens along with muscle relaxants being given. So it's like a short procedure about which the patient wouldn't know. But the thought around ECT comes by what one has seen in media. And the second thing is, ECT was identified before muscle relaxants came. So there was a period in time where, yes, those rigorous fits because of the ECT did take place. And then when you move forward, you started having these other medications. Then the SSRIs finally came. And then finally, you had a designer medication, so on and so forth. And as we stand today, you have evidence about most psychiatric disorders having an excellent response to modern day treatment. Most people, even if you look at, let's say, something like schizophrenia, you are well aware of the fact that 60% of people would lead an absolutely normal life. 20% would still have some symptoms. It's only 20% or so where there is going to be a concern. Now, I gave the example of schizophrenia primarily because of the way we look at the illness. And obviously, when you look at other illnesses, the treatment, the efficacy of treatment is a lot more there. Similarly, when we look at the entire aspect of psychotherapy from the earlier analytical Freudian, where one theory came, then, it was readjusted, rejected by a few people, then a new theory came because it was an evolving science. Take the example of COVID. In the last 1 year, how many times we have changed what medication works? We started with one, then the guideline came, no, not effective, then had something else, not effective. Why? Because it's an evolving science. As you know more, you learn more, you implement more. The same happened when therapy also became a part. And then as you moved forward with more clarification on diagnosis came, what that did was personal discretion, personal opinion about what a person may call an illness that changed drastically. So today, when you look at what is diagnosis, there has to be very clear impairment in functioning. If impairment in function is not there, it can't be a disorder. There is a structure to diagnosis. What it does is it prevents unnecessary personal discretion and subjective aspect of diagnosis, whether you follow the ICD-10 or ICD-11, sorry, and or DSM-5, you would be able to reach wherever you are in the world with almost a similar diagnosis. So diagnosis became standardized, which was very important. Similarly, treatment got standardized. So today, if I speak as a psychiatrist, let's say if I see a patient of major depressive disorder, and be very clear, depression is the single largest illness in the world. WHO says 300 million people globally suffer from depression. So let's not have a conversation and even allow conversation about is it an illness, or is it overdiagnosis, or is it underdiagnosis. It is the single largest illness. Overdiagnosis is not a problem in psychiatry worldwide or mental health worldwide. Underdiagnosis is, because lesser people than who require help seek help. And that happens because of the nature of conversations that happen in mental health. So quackism in mental health is a concern, because anybody can write anything. And in today's ever prevalent, ever intrusive, unhindered digital space, anybody can say anything that they want, that they wish. So if I have thyroid, and if I am taking a medication, but I also think that by taking some other, by doing something else, my thyroid is better, and I start writing about it, how many people will say that stop your thyroid medicine and do only what you think has worked for you? We won't say that. But the moment it starts coming in the field of psychology, psychiatry, mental health, all of these things start trickling in. So understand the history. We're still looking at just about 60, 70 years. And that's why one needs to keep understanding that it's the conversation which is an issue. Now, whether it is the portrayal in media, whether it is the conversation in social media nowadays, whether it is the quackism, which basically is people who proclaim to be expert are not experts and keep giving advice. And a lot of people are not able to filter between the credible advice and advice which is not coming from a credible source. So the question should be, how do you identify credibility? How do you know the information reaching out to you is credible or not? There is science will keep on evolving. If you look at DSM-3, DSM-4, DSM-5 now, diagnosis also evolved because science can't be rigid. If it will become rigid, then it's not science. You keep evolving, you keep learning. So yes, the medication which was used in 50s for psychosis is hardly used now. Yes, ECTs which were used a lot earlier with the advent of newer medications are hardly used. So why that happened is because constantly science evolved with evidence that was there. So how do you decide on what to do? Let's say a patient of depression comes to you. You may be a therapist, you may be a psychiatrist, you may be a general physician. How do you decide? The evidence is very clear. You first reach your diagnosis, rule out the comorbidities, see the severity, mild to moderate. You decide that you give therapy, and based on the symptoms, you may also decide on medications. Moderate onwards medications is a must. In severe cases with suicidal ideation, look at what other medications can be given. That's one. Then let's say if I'm as a psychiatrist treating somebody with medications, I am very clearly aware with evidence what is my level 1 of medication. If that doesn't work, what is my add-on? What is the adjuvant? How do I decide? So do I look at the diagnosis which is incorrect? Do I look at an add-on medication? Do I change the medication? What are the levels? And what all I can give and I can't give? That is very well defined. What happens is that we keep on getting also a lot of people who also end up talking about what they believe. And since it is psychology, a lot many more people consider themselves to be experts. I wish there were so many experts in the world. I mean, India has a shortage of over 500 experts in the field. So if all those proclaiming to be experts, if they were actually experts, it would have been an absolutely wonderful thing for the branch and for the country, world, and the quality of life. So that's why this topic becomes important. Even though it's a given that therapeutic intervention, biological or psychosocial, are very well evidence-based worldwide. But A, there is still a lot of quackism happening which needs to be addressed. And B, a lot of times, like other branches also, experts of the field, rather than following evidence-based treatments, start doing their own versions of it, which is where a concern lies. I think it is ethical, and a lot of you are young people, students. Keep your ethics always with you. If your ethics are going to be with you, you will be on the right side of science. Ethically, you stick to evidence-based treatments. For example, DBT is effective in borderline personality disorder. Robust evidence, studies have happened, double-blind studies have happened, observer variant studies have happened. There is data that is out there. Read more research, read more articles, because you'll keep upgrading your own knowledge. See how treatment paradigms are being decided and how they are happening. So treatment needs to be decided on research, not only on clinical experience. Clinical experience needs to follow the standardized processes where it could be repeated with all other variables taken care of. And yes, if it is evidence-based, that yes, this experience of yours can be replicated across the board at various aspects, then why not? That is a new learning for the science. That's the way you understand it. So treatment protocols are standardized, they are reliable, they are replicable. That's why it becomes evidence-based. It's based on research, not only based on clinical experience. There are well-defined algorithms for most treatments. That, okay, this is step one. So for example, if I give an antidepressant, when do I review again? I know it will take about 10, 14, maybe 3 weeks based on what salt I have used. So my review would be accordingly. And I know that if there is a psychosocial stressor, then what form of therapy would be done by a therapist? Or let's say if somebody is having trauma, then what kind of therapy works? All of the various kinds of therapies have their own place. So what happens is, now look at the other side, which is quackism. Let's say you are a person who studied a particular kind of therapy only. And just for an example, I'm saying, because it comes to my mind straight away, let's say hypnosis. Now, that does not mean that you have the luxury, the liberty to start using hypnosis wherever you want. Because if there is no evidence of treatment of depression, in treatment of depression of hypnosis, you can't be using it. You may be an expert, but you need to pick and choose where you apply that particular style of therapy. Now, once you stop doing that, that's when the concern happens. That's the ethical dilemma. That's what hurts the field by and large, because we lose base with evidence. So if you're doing CBT, for example, and you decide that, oh, in my style of CBT, this variant works. Now you start applying that across the board, irrespective of the diagnosis, or relaxation guided imagery, for example. And now take the same example in medication. Would all cardiologists give the same blood pressure medicine to all people for blood pressure? No. They would pick and choose the molecule based on so many other factors. Similarly, psychiatrists, neurophysicians, general physicians would be using the same aspect, various algorithms that are there, which have been proven for time that this is how it is. And also understand, as we move forward in life with insurance sector coming in, and I hope it comes in sooner and more effectively and is applicable for OPD and for therapy, you will need to stick to more and more evidence-based work. And this is what one needs to understand. Of course, there are limitations to research. That's why you have more research. That's why I mentioned it's an evolving science, like any science is evolving. But just because you have research which keeps on happening and bringing newer light, that does not mean you question in terms of, you question what is there, but you don't reject what is there. You don't say this may not be effective and claim something else being effective, which is not even tested. And that's something we all need to understand. And that's why I feel ethics need to be on track. You need to be clear, sure about your own branch, your own approach, the seriousness and the responsibility that should be there for you to be able to function in your role. And that's what is the need of the hour. The need of the hour is all mental health experts should be a part of all possible conversations happening in mental health around their space so that they are there to rectify all myths that come and hurt the entire perception of the branch, more importantly, that reduce help seeking behavior, which is abysmally lowered by stigma, lack of help seeking, judgmentalism, and the boundaries. All of these need to be done. I'll ask you, I'll share a couple of questions. I've been taking these, you know, various forms of courses and internships for very young students also. And you'll get a student who says, why can't I do a therapeutic session in a cafe in front of 50 people in the middle seat? How is that even possible? What boundaries are we talking about? Now, you just can't say I saw it in a film or I tried it with two people, it worked well, so now I can do it. No, there's no evidence to it. The structure to therapy has its own rationale. You can't take a walk in the park in the name of psychotherapy. So these aspects need to be understood. No boundaries, algorithms, research, the fact that there is a science and science will evolve, that understanding needs to be had. So coming back to our topic, a lot of times this topic would have never happened. In most branches, this would have never happened. But it's happening because there's a reality that there is both quackism, personal discretion, subjective expressions that a lot of times take precedence or more space than the evidence, which is clearly about the efficacy. And the efficacy of most treatments for most illnesses are very, very significant, undoubted significant. And that's why we do harm when we question something which is efficacious, because hundreds of people who could have been helped are not helped. So responsibility, not just empathy and compassion, responsibility is something that needs to be there when we start talking, when we talk about psychotherapy, psychology, mental health, psychiatry, and the branch. On that note, I shall start taking questions if there are any.
Thank you, Dr. Samir, for a very detailed and informative session. Much needed talk for all of us. We do have a few questions from the audience, so without any further delay, let's head right to the Q&A session. Are there any sources from which evidence can be gathered so that we can back up mental health?
Read, young people, read. What do you mean? Is there any source? There are hundreds of sources. There are journals which are there. There are textbooks which are there. Right? It's very important to understand this. In fact, I believe that more and more academic conferences and academic institutes need to have research and research article reading, textbook reading very integral to our educational system. That no student should ask us a question that from where do I read?
Absolutely. How helpful is it for an individual to look into evidences before seeking support for mental well-being?
You're talking about the client here and not the therapist, right?
Yes, sir.
A lot. So ask yourself the question, how many people who would have a hemoglobin low will actually start looking for various aspects of hemoglobin? And all of us know that how many, there can be so many causes. So you'll go to the doctor will say that, yes, in today's internet era, people will be reading a lot more because there is information out there. But a lot of these people would also not be able to distinguish between a credible source and a source which is actually having no credibility to say what they are saying. So I am nobody to tell somebody, or none of us is somebody to tell somebody of their free will and right that they would want to first look at something. Feel free to do that. But ensure that you reach the right resource. That's why media literacy. That's why I said all people in the field should be present in the digital space, talking more and more about the science.
Another question that has come up is, How can we implement evidence-based mental health support in our daily lives?
See, when you talk in terms of support, there are two aspects to this. One would be, which is more lifestyle, and how do I incorporate a healthy lifestyle which is good for my mental health? That is one thing. Second would be nature of support. Now, nature of support, if you're asking as a non-psychology expert, it will be a different answer. If you're talking about as a psychology expert, then your answer becomes very different because you have a different hat that you are wearing and a responsibility which comes with very clear boundaries and expectation. That's how you understand. So, and how much evidence would you need to know that good nutrition, good exercise, hydrating well, saying no to substances is good for health? How much evidence would you need that basic breathing exercises, relaxation, creativity is good for health? I mean, there is robust evidence about how it helps in immunity, how it helps in your overall well-being. I mean, how many countries today even try looking at happiness? We look at having happiness curriculums, loneliness ministers, but we don't look at what we can do, which is out there, which is bringing self-correction, which can actually bring a sense of better quality of life.
Absolutely, sir. We do have a question from the audience, namely Devanshi is asking, Sir, what do you think about online therapy by licensed therapists? Apps like BetterHelp are advertising the same.
Two aspects. I think online therapy is here to stay. I believe online therapy, especially for a country like ours, is something which is important. If online treatment would not have been allowed, especially if I'll say this as a psychiatrist, then in the last 1.5 years, so many patients would have struggled because of the way the lockdowns and all affected our lives. That's one aspect. Secondly, I also feel that online treatment brings a lot more of cost effectiveness to treatment. And why I say this is a person who's coming to see me from the other part of my country might take a day to reach me. 4 or 5 working days of 2 or 3 people accompanying are all lost for one little consult where I'll be asking that individual to come after 3 or 6 months. Now that can be stopped. That's one aspect. I do feel that it is absolutely fine to do online therapy, but I feel that all aspects of boundaries, science, all aspects should be taken care of while we are doing it. Now coming to the aspect of talking about it in the open space. I have a few issues of how it can be said. I think it should be bare minimum following all medical guidelines or ethics that are there for medical doctors. I think they should apply to all form of healthcare practitioners, including psychologists, which means you can tell somebody that you are a therapist and you also do online therapy. That's about it. But you can't go beyond that. I have my own issues about the way sliding scales are being used. Sometimes it creates a lack of transparency, which I've never been comfortable about. There are various aspects, and like I said, we need to evolve, but we need to evolve keeping our ethics with us.
Completely agree with you on that, Dr. Parikh. Really got to know about some insightful and useful information. Wish we could take this discussion further. However, it's now time for our next panel discussion. But nonetheless, thank you so much, Dr. Parikh, for your time and hope to hear from you in the future.
Thank you.